Welcome to the National Kidney Foundation's First Steps to Transplant webinar. We're so glad that we're able to gather virtually with you all today and share this important information. Today, you'll hear all about what it takes to get started with the kidney transplant process. You'll also learn about the different types of transplants, what it takes to be a living donor, as well as hear a little bit about how other kidney patients shared their story for a living donor transplant. Before we get started today, we'd like to thank our sponsors. First is our presenting sponsor, the University of Maryland Transplant Center and Medical Center. Our mission sponsor today is Veloxis Pharmaceuticals. Without their support, we would not be able to bring this program to you today. It gives me great pleasure to introduce Eileen Willey. Eileen is the Director of Transplant Quality and Regulatory Compliance and Interim Senior Transplant Administrator for the program in transplantation. Eileen is an experienced transplant quality leader, a former federal CMS transplant surveyor and hospital consultant in quality, patient safety, and regulatory accreditation requirements. For more than 30 years, she has had a progressive hospital leadership career in trauma, critical care, emergency management, and hospital quality. A national speaker, she holds a master's degree in nursing from the University of Maryland and a BS in nursing from the University of Delaware. Eileen, it is such a pleasure to have you with us today. Please take it away.
Welcome to the Big Ask, Big Give. My name is Eileen Willey, and I'm the Transplant Quality Director and Transplant Administrator for the programs here at the University of Maryland. I thought I would take just a couple minutes and cover some of the issues that I think would be important if I were coming today. The first thing is that the University of Maryland Kidney Transplant Program has some of the highest volumes in the region. That's important when considering the hospital. The second thing is that our living donor survival rates at 1 year are among the highest in the nation. That's also important. The third thing is that our surgical techniques are some of the most innovative and least invasive for both the donors and recipients. The fourth thing is that our living donor coordinators walk with you every step of the way through evaluation, donation, and beyond. And lastly, we know that this is a big decision for you, your family, and others. We know that you want to help. We know that you are hopeful, but we also know that you might have some fears. So our goal here today is to introduce you to our team and help you make an informed decision. Welcome to the University of Maryland, and we wish you well.
Thank you, Eileen. Next, I'm honored to introduce Dr. Maluth. Dr. Maluth is the Professor of Surgery, Director of Program in Transplantation. Dr. Maluth is a transplant surgeon with more than 19 years of experience in clinical and translational research. He is also the Director of the Program in Transplantation at the University of Maryland School of Medicine and manages IMS and transplant patients clinically. He has expertise in kidney, liver, liver transplant, living donor liver, pancreas, and renal transplantation. Dr. Maluth, it is always a pleasure to have you join us. We are looking forward to your remarks.
Good morning and welcome to the National Kidney Foundation Big Ask, Big Give 2022. I'm Daniel Maluth, Director of the Program in Transplantation at the University of Maryland, and I want to welcome you. Since 1968, University of Maryland has been one of the lead in transplantation in Maryland and across the country, and continue to be. Our members, several of those you will meet today, work daily to provide you with the best experience for the transplant process, as well as information that you may be needed for transplantation. So again, feel free to ask questions during the sessions, and I hope that you enjoy the day. Thank you very much, and welcome again to the National Kidney Foundation Big Ask, Big Give 2022.
Thank you, Dr. Maluth. Always great to hear from you. Today we're going to look at 4 options that you see below to see what you hope to learn today. The transplant evaluation process, dialysis options, information about different types of transplants, and what to expect for life after transplant. Please take a moment to type in the chat box which of these are most important to you and what you hope to learn today. Today's program is chock full of a lot of great information and resources. As you can see by our agenda, we'll be covering a great variety of topics that relate to patient and family education. Later today, we're going to have a breakout session where you can join the doctors for Q&A. We hope that you'll join us for that. We'll be providing resources to help, exploring what's next with your action plan, and wrapping up the first session with evaluation. After the breakout rooms that was mentioned, I hope that you'll come back to us for the second part of today's program, where we'll explore finding a living donor. Now I'm extremely pleased to introduce our presenter for today's session, Dr. Hararian. Dr. Hararian is a transplant nephrologist and an attending physician on transplant medicine and general nephrology services at the University of Maryland Medical Center. He received his medical degree from Tehran University of Medical Sciences and his Master of Public Health degree from Johns Hopkins Bloomberg School of Public Health. He completed his residency in internal medicine at Wayne State University, Detroit Medical Center, and later went on to complete fellowship training in general nephrology at Johns Hopkins Hospital and transplant nephrology at the University of Maryland Medical Center. Before joining the medical center, Dr. Hararian was the medical director for the kidney and pancreas transplant programs at Harper Hospital in Detroit. He is now the medical director of the kidney and pancreas transplant program at the University of Maryland Medical Center. He is also the director of clinical research in transplantation in the Division of Nephrology. His major clinical and research interests are acute and chronic antibody-mediated graft injury and BK virus nephropathy. He specializes in kidney transplant and pancreas transplant medicine. He has led efforts to establish institutional protocols for diagnosis and treatment of these important causes of graft dysfunction and graft failure. Dr. Hararian has more than 60 peer-reviewed publications in major transplant and nephrology journals. He is an editorial board member of transplantation and clinical nephrology journals and a reviewer for several transplantation and nephrology journals. Dr. Hararian, it is with great gratitude that we welcome you today, and we look forward to your presentation.
Good afternoon. Thank you for joining this seminar. And a special thanks to the National Kidney Foundation of Maryland, Patty Dash, and her wonderful team who arranged for this program. In the next 40-45 minutes, I'll try to talk a little bit about the kidney failure and the treatment options we have for patients with kidney failure. The kidneys are a pair of organs that play an essential role in maintaining the appropriate chemical composition and fluids in the body to let the other organs function properly. They regulate the amount of the water in our system. We drink different forms of fluids every day, and metabolism in the cells also leads to production of some water. And the kidney removes this extra water from the body to keep the fluid amount in the body in a regulated way. It excretes a number of the toxic products that are a result of the metabolism in different cells. And also it regulates the different chemicals that we ingest on a daily basis to prevent accumulation of these products and chemicals and toxins in the body that could cause dysfunction of all other organs. Kidney is also an endocrine organ. It produces different hormones. One of the important hormones that kidney produces is called erythropoietin, that makes the bone marrow to make red blood cells. That's the type of cells that causes anemia if it is not produced in adequate amount. Kidney plays an essential role in regulating our blood pressure, and directly through control of the blood pressure and controlling the chemistry of the body, it affects the heart, brain, vascular system, and basically all organs. If the kidney cannot remove the fluids from the body as it's supposed to, the fluids will build up in the body and lead to flooding of the lungs and breathing troubles. Increase in the amount and concentration of the chemicals like uric acid or calcium, phosphorus, and a variety of other chemicals can lead to dysfunction in the joints, inflammation of the joints, muscle dysfunction, and very importantly, dysfunction of the brain, because these chemicals and toxins impair the proper function of the neurons. So kidneys health is essential for health of the body and health of all other organs. But unfortunately, small portion of the population experience a variety of different forms of kidney disease that progress over time and lead to kidney failure. And the kidney failure without treatment is incompatible with life. And the individual cannot live long without minimal function of the kidney or replacement of that function by another way. Fortunately, we have treatment options for kidney failure. The more common form that I'm sure that you're familiar with is dialysis. In dialysis, we try to artificially clean the blood by removing some of the chemicals that we could with the technology we use to reduce the burden of the toxins and chemicals that build up as a result of kidney failure on organ systems. The more common types that are in use is hemodialysis, where the blood is removed from the body, is circulated through a machine, and using a special fluid, we try to remove some of the chemistries that are toxic and return the partially cleaned blood back to the body. Most patients who use this modality have to go to a dialysis center, usually 3 or 4 days a week. And each time they stay on the machine for 3-4 hours. It takes a significant amount of time out of a patient's life. It's oftentimes is draining and exhausting. And in no way it does the job that the normal kidney does. The other option for hemodialysis is home hemodialysis, that the patient undergoes dialysis at home, usually in the evenings after the working hours. Generally, the time is shorter, but it is done more frequently, usually 5 or 6 days a week. Each one of these two options have some advantages and some disadvantages. For home hemodialysis, it's easier to manage the amount of the fluids and some of the chemicals that build up in the body. The other home option for dialysis is peritoneal dialysis, that we use the peritoneal cavity to remove some of these chemicals that we talked about, using a special form of fluid that we enter in the abdominal cavity, let it sit for a while, and then remove it with removal of some of the toxins and replace it with the fresh fluid. Usually it's done by help of a machine called cycler overnight, but sometimes it is done manually during the day. Both home hemodialysis and peritoneal dialysis give more liberty to the patient to run their regular life, going to work or some other activities. The alternative, which generally is a much better option, is kidney transplant, that either can be from a deceased donor or using a kidney from a living donor. For majority of the patients with kidney failure, kidney transplant is the best option, particularly transplant from a living donor. But there are small portion of the patients that, because of the variety of different medical issues or other psychosocial issues, they may not be a good candidate for kidney transplant because it may not be safe for them for those reasons. Transplant gives you a kidney that functions like a kidney and does what the kidney is supposed to do. So, great majority of the limitations that one has on dialysis in terms of fluid intake or the type of diet are removed after transplant because the kidney performs its function appropriately. With improvement in the anemia and even the resolution of anemia, the energy level comes back. Patients feel refreshed. They get back to regular activities that they used to do. They get back to work and become functional, which is one of the purposes of transplant, to get patients back to their normal life, to productive life. Also, the big advantage of transplantation is prolonging life compared to dialysis, because dialysis over time, since it cannot remove all the waste products properly, it leads to dysfunction and disease in different organs. And transplant alleviates those effects and leads to healthier organs and longer life. We have to mention that transplant is the best option for most patients, but it is not without risk. Inherently, there is some risk associated with the surgery itself because it's a major surgery, and like any other surgery, there is potential for some risks and complications. And after surgery, the patients need to take rejection medications to prevent their immune system to attack the kidney and destroy the kidney. because the kidney that comes from a donor, either deceased or living donor, is foreign to one's body. And the immune system will recognize it as invader and try to destroy it. So we have to use these medications to calm down the immune system so the kidney can function appropriately. So these medications have their own potential side effects, like any other medication. The major side effect that is common among all of those anti-rejection medications is increased risk of infections, because our immune system protects us against different forms of infections. And if we weaken the immune system, that risk goes up. Certain forms of cancers also seen more often after transplant that we monitor for to detect them early and treat them. Now, most of the transplant procedures are successful and the patients enjoy the benefits of transplant for years. But how long the kidney is going to work properly varies from patient to patient and depends on a different set of number of facts and factors related to the patient and the medical problems that the patient has, the type of organ that the patient receives, and its quality, and the course of transplant after surgery. Now here, I'll stop to watch a video. We will watch Cindy and Maria's journey after the transplant.
So I grew up in Brooklyn, Queens. I used to dance ballet. High school, everything was pretty much normal. I graduated high school a year early. It was only until about 14, right when I started high school, that I started developing symptoms of kidney failure. And then I was diagnosed with lupus and end-stage renal failure.
I never doubted that I was a match. I knew I was a match. I knew that I gave birth to Cindy, and Cindy was mine, and no one was going to take Cindy away from me. Not from me, not from society, not from anyone. So I went and I got tested.
I was a little scared, but I really didn't know what I was getting into. So I just kind of went with the motions and let it all happen. And yeah, as pediatrics, they take really good care of you, and everything went by so quickly, you didn't really have time to process it all.
When I woke up, the first words out of my mouth was Cindy. Where's Cindy? I needed to see my daughter. So my son put me in a wheelchair, rolled me all the way down to the pediatric unit. And I saw Cindy. I was able to get up. That was the first time I got up. I kissed her, I hugged her, and I knew she was okay. Once I knew she was okay, everything else was going to be okay.
After the surgery, I felt great. It was new life, it was new freedom. It was less medication, it was less pain, it was less tiredness. It was freedom.
Everything is just history then, until just recently.
So my health slowly declined. About 2 summers ago, I had my first episodes of rejection. I was placed on dialysis, and that was horrible. I don't wish that on anyone. You really have no life. I had to drop out of school, take medical leave from work. And my father and I didn't have the best of relationships growing up, because my parents did get divorced. I lived with my mom. I remember he came to see me in the hospital, and he was sick. You can see the hurt, because we never really had a relationship. It's almost like a stranger. But he did. I'm very grateful, and him and my mom just worked through it. It worked out perfect. We went through a lot of testing for the next transplant. My father wasn't a donor for me, but we got involved with the Donor Exchange Network, where if he donates to someone, I would be able to receive. It's been 4 weeks since my second transplant. It feels amazing to be sitting here, no longer on bed rest. I'm driving, wearing whatever I want again. I'm so grateful.
I got my daughter back. We could go shopping, we could go to the library. We could do amazing things now.
To a donor, my gosh, you're a hero. You're giving life. I have my dreams back. I mean, I want to be a nurse, but I want to do so much more, and it's all possible now because of the donor. I can't wait to meet my donor and just, it's family. I have a piece of you in me, sustaining me, keeping me alive. Like, we're family. The big ask to me is asking someone to be a donor for you, asking them to get tested, asking them for a piece of them to have life again.
If you could donate, there is no reason why you can't. I donated. There's nothing wrong with me. I'm living a healthy, normal life. I eat well, I exercise, I'm still working. People are not that educated as far as being able to donate. They're afraid. They think something's gonna happen to them. Once you educate them, I think everyone's gonna go out there and donate.
Well, I gotta say thank you for the first kidney. And I gotta say thank you for standing by me for the second one. That's it, new life. It's all over, no more fighting.
I will always fight for you. And you know, I will always give you life. I love you.
Thank you, I love you too.
Now we watched this wonderful journey. Let's talk about factors that need to be considered for kidney transplantation. First question is, who can get a kidney transplant? I can say that almost all ages, both children and adults, could be a candidate for kidney transplantation. So the number for the age is not in itself a limiting factor. Every patient who wants to be transplanted will undergo a detailed, comprehensive evaluation of the health, both in terms of the medical issues and psychosocial factors to make sure that transplantation is safe for that individual, and as a result of the transplantation, the patient will enjoy a healthy life after the surgery. And if a problem is detected that needs to be addressed, we identify that problem during this evaluation and ask the patient to get appropriate help from a specialist to address that problem before proceeding with the transplant. Now, one might ask, how do I start the process of getting a kidney transplant? So the first step is getting connected to a transplant center to start the evaluation process. Usually, the nephrologist who provides care for patients with kidney failure is the one that refers the patient to the transplant center. And some centers, including the University of Maryland Medical Center, accepts self-referrals, which means that the patients can directly contact the transplant team and request evaluation for transplant. As you see on the slide, the National Kidney Foundation is a great resource to help you find a transplant center in your area, and you can contact them with the ways you can see on this slide. Now, for each transplant center, there are certain guidelines for deciding who is a proper candidate for kidney transplantation in that center. There are some common processes among all transplant centers, and there are some that are maybe specific to a single individual transplant center. The common parts of the evaluation is an extensive medical and surgical history to learn about the type of medical issues that the patient has been treated for in the past, the type of surgeries that the individual had that might affect the surgery for transplant. Each patient undergoes a physical examination by the specialist transplant providers. And they also undergo psychosocial evaluation by our dedicated social workers who sometimes need to get help from specialists like psychiatry team or other support teams to help to complete this evaluation. In addition, each patient has to undergo a battery of blood tests to make sure that the patient is appropriate and suitable for kidney transplantation. One question that oftentimes comes up when we see the patients is regarding potential for pregnancy after transplant. As you might know, kidney failure, because of the change in the different hormone-producing organs and also the chemistry of the body, have a lower fertility and reduced risk of becoming a parent. Kidney transplantation alleviates those issues to a large extent. So pregnancy is a reality, the potential for pregnancy after kidney transplantation. And for especially women who would like to become pregnant after transplant, we educate them that they need to inform the transplant team ahead of time, at least a few months ahead, so that we adjust their medications, because some of the rejection medications are injurious to the fetus. And we need to change those medications to different ones so that the pregnancy can proceed safely without harm to the fetus. So that's why we let the patients know to inform the transplant team ahead of time. The big question always comes with any procedure is who is going to cover the cost of transplantation? Fortunately, Medicare covers about 80% of the cost associated with evaluation process and the different tests and studies that need to be done, the transplant operation itself, and the hospital stay after that, the follow-up care for the clinic visits and the blood and urine tests that are required for monitoring of the kidney. And also it covers a great part of the anti-rejection medicine costs as long as the kidney is functioning. Usually the private insurers and sometimes some state programs like KDP in the state of Maryland cover the rest of the cost and relieves the patients from carrying this burden. Some programs may have certain requirements to become eligible for those coverages, including U.S. residency for some of those. Our social workers and the financial team are always available to help you to find out what kind of coverage you will have after transplant. Now, one needs to know what factors may stop one from becoming a candidate for kidney transplant. There are some general rules and factors that almost all transplant centers consider as a stop to transplant. But there are some factors that may be specific to certain transplant centers. The common factors that may affect whether one can be a transplant candidate is presence of current or recent cancers. It depends on the type of cancer and its treatment. For example, for non-melanoma skin cancers that are just treated with simple surgical removal, one still may be eligible to proceed with transplantation. But for a different type of cancer like melanoma, we require at least 5 years of remission before consideration of transplant, because the rejection medications can cause return of those cancers and put the life of the patient at risk. Presence of serious heart disease could be prohibitive because the patients need to be able to stand the stress of the surgery, and also the impact of events and the medications after the surgery. So that could be something to delay or at least stop the transplant process. If the heart disease is something that can be treated, like if someone has coronary artery disease that requires a procedure, either in form of stent placement in the coronary artery or bypass surgery, then we still could consider transplantation after the patient has undergone that corrective treatment. Presence of active infection is a factor that would stop proceeding with the transplant procedure, because if one has active ongoing infection, starting immunosuppressive drug can cause worsening of the infection and can put the patient's life at danger. So we need to make sure that there is no active ongoing infection. And there may be other factors that may increase the risk of operation or the treatment after the surgery that may not be safe enough for the patient to proceed. So we evaluate all the information that we get from the evaluation process that we discussed. And in a multidisciplinary way, we discuss those pieces of information about your health. And we make the decision that if one is a suitable candidate to proceed with transplantation, or there is something that needs to be treated first and then proceed, or Sometimes, unfortunately, we may feel that transplantation is not safe at all for that individual patient. During the transplant surgery, usually the native kidneys are left untouched. We don't need to remove the kidneys. They don't do any harm, and they don't do any problem with the procedure. But there are some patients that their kidney or both kidneys need to be removed. For example, in patients with polycystic kidneys who may have very large kidneys that fill up the space of the stomach completely, the kidneys may need to be removed to provide space for putting the transplant kidney. Or if one kidney or both kidneys have cancerous lesions, they may need to come out before the surgery. If the lesion is very small, in some cases it may happen even along with the transplant surgery. But sometimes it needs to, the kidneys need to come out beforehand. Usually the kidney is placed in the lower part of the abdomen, in the pelvic area, because that's where we can connect the ureter to the bladder to drain the urine and connect the artery and the vein of the kidney to the main artery and vein in the pelvic area. The operation usually takes 3 to 4 hours. But again, depending on different factors, it may be a little bit less or a little bit more. After surgery, obviously because of the surgical incision, there is some soreness and pain. Usually with our pain medications and the regimen we use, the pain is well controlled after operation. We ask the patients and we encourage them to get out of bed and be up and around the day after surgery. And usually they get discharged home after a few days and recover at home. Now let's talk about the 2 types of sources of kidney for transplantation. We'll start with kidney transplant from deceased donors. So we talked about the evaluation process, that we evaluate the patients for the purpose of listing the patients on the waiting list, on the national waiting list. When we deem a patient a good candidate for transplantation, they need to be listed in this national database so they can be offered kidneys. So currently, the waiting list is close to 100,000 patients. And unfortunately, we don't have that many kidneys available from deceased donors. Every year, there are only maybe around 17,000 kidneys that are available to transplant some of the patients on this long list. But that's the first step, to get listed for kidney transplant. As I mentioned, sometimes one is not a good candidate for being transplanted at the time of active issue until it's resolved. This type of patient could be listed, but they would be in the inactive status on the list until that active issue, like an infection, or if they have a wound that needs to heal, is completely healed and the infection resolved before we can activate them on the list for potential kidney offers. The transplant team and the coordinators would be the best source of information regarding one's status on the waiting list. So this waiting list is a national list and is managed by the United Network of Organ Sharing, or UNOS. To get a kidney transplant from a deceased donor, one needs to be on this list. And with certain algorithms taking into account different factors, that some of those factors are seen on the slide, they get priority for kidney offers. As I said, we only have 17,000 kidneys on a yearly basis for transplant, and about 100,000 patients waiting for transplant. So there is a gap between the demand and supply. So we need to prioritize the patients on this list to see who gets the kidney offer first. And the number of the factors that are major factors for this algorithm and decision making is the blood type and degree of sensitization, which is usually the result of prior transfusions or pregnancies or even organ transplants. The size match sometimes comes into play. A small child may not be able to accept a kidney from a large adult because of the space restriction in the abdominal cavity. The time that one is on waiting time plays a big role. For those who are on dialysis, regardless of how long they have been on dialysis when they start the evaluation and listing process, the clock starts ticking from the time of dialysis. So you won't lose any time if you are a little bit late to the game. You still will get that benefit, that your start time starts from the time of dialysis. However, for patients who do not require dialysis, they need to start earlier on time. What is that time? We use a variable, a lab test or calculation we call estimated GFR that you probably have seen on your blood test results. And that indicates the function of the kidney. When it gets to 20 and below, that's the time that's best to start evaluation for transplant and getting listed, because it may take months and even years from that moment or that time until you need to be on dialysis. So to avoid losing that time, precious time, you need to start very early. Other factors include being a child, because the children need a transplant to have a healthy and long life. If one had donated a kidney in the past, they need credit, and they get credit because they had sacrificed to help another patient, and now we need to give them priority. The other factors include the distance of the transplant hospital that the surgery is going to happen from the hospital that the donor kidney is obtained and shipped to the transplant center. There are also some algorithms to calculate the expected longevity after transplant, and that also comes into account in the algorithm that the UNOS uses for prioritization of organ offers. The two important principles that by law are considered for this prioritization are the justice, the rule of justice, and also medical utility that are taken into account in this prioritization scheme. Now, one question that always comes up is how long I will need to wait to get an offer and be transplanted. Just looking at the disparity between the supply of organs and the number of the demand of the kidney transplants list, you would guess that you would need to wait a while, which usually is many years. There is a chance, but a small chance, that one may get transplanted very quickly based on a certain characteristics, but that's a very low likelihood. Great majority of the patients need to wait for several years to get transplanted. On average, we can say that it's going to take 3 to 5 years from the listing. Again, depending on different factors, including blood type or degree of sensitization, this may be much longer, for 6, 7, or 8 years, or in some occasions, it might be a little bit shorter. Again, the transplant team would be the best source to ask about that kind of expectations for waiting time. Now that we talked about the deceased donor transplant, let's move to a more exciting part, the living donor transplant. So what is living donation? So it is when a healthy individual donates a kidney to another patient with kidney failure who is in need of treatment. This donor could be anyone, could be a family member, like a parent, a child, a sibling, cousin, a second cousin. It could be a spouse or a partner. It could be a friend or just an acquaintance. Or even sometimes it could be completely a stranger. We call them altruistic donors or Good Samaritan donors. The reason that we accept a healthy individual to donate a kidney is we can have a healthy life with just one kidney. So that's why we advocate kidney donation, living kidney donation for transplantation. The medical costs of the whole process of evaluation and the surgery for the donor is covered by the recipient's insurance. So there is no related financial burden on the donor. Now let's address some of the misunderstandings and misinformation that we sometimes hear being asked. Is it true or false? A kidney donor doesn't need the same blood type as the recipient. So I'll give you a moment to think about it. That's true. You don't need to have the same blood type to be a donor to a recipient. It needs to be a compatible blood type, not the same blood type. For example, blood type AB can receive a kidney from blood type O, blood type A, or blood type B. On the other hand, blood type O can receive a kidney from a donor with blood type O. So it differs from blood type to blood type. But even if the donor and the recipient have incompatible blood types, we have ways to get around it, and we'll talk about that in a few minutes. Now, what are the benefits of kidneys from living donors? So the living kidney donor comes from a healthy individual. So the quality of the kidney is very good. It's a healthy kidney. In contrast to the deceased donor kidneys, this type of kidneys usually work right away. Even on the operating room, the kidney starts making urine. The function generally is better. So again, looking at that calculated function of the kidney, eGFR, it usually is higher than the eGFR for the deceased donor kidney. And more importantly, the kidneys last longer. A kidney from a deceased donor lasts on average about 8-9 years. Could be less, it could be more, again, depending on different factors. But in contrast, a kidney from a living donor, on average, lasts more than 15 years. So it's a very big difference in terms of the longevity of the kidney. The waiting time is very short because all the time we need is for evaluating the patient and evaluating the donor. So the transplant can happen as early as a few months from the time that you start the whole process. And that way, if you're not on dialysis yet, you could get transplanted even before need for dialysis. Or if you're on dialysis, we won't need to wait long for years to get a transplant. You can get transplanted fairly fast. And that way, you avoid the adverse impact of prolonged dialysis on your different organ systems. The quality of life changes tremendously. And the sooner it happens, the better. The life expectancy increases. And as I said, the living donor kidney transplants are better than deceased donor kidney transplants. And not only you would help yourself by getting transplanted faster with a better quality kidney, you will also help other patients because they will have one less patient to compete with in that long list that I mentioned. So that's another factor to think about. Now, who can be a living donor? I tell my patients two things. One, don't make decisions for others without their involvement or them being a donor or not. Oftentimes, I see that the patients say, oh, I have adult children, they have expressed interest to helping me with the kidney, but I don't want to get a kidney from my kid or my spouse or my friend. Since all the donors are eligible donors are adults, at least 18 years. In some centers, it might be a little bit higher. They can make decisions on their own. That's their right to make a decision. So why one would stop them from making their life decisions? And that's what I tell my patients. You don't have the right to decide for them. Let them decide. I'm sure that your daughter or your son, your husband or your wife would be much happier seeing you healthy, running your normal life than going to dialysis 3 times a week and coming back exhausted and unable to do anything. So why are you trying to remove that joy from your loved ones? Let them decide. And the other thing that I tell the patients that you're not a medical professional, so don't make judgment that your potential donor is going to be healthy and a potential candidate for donation, or has some issue that he or she cannot. Leave it to the transplant team to decide. We perform an exhaustive and comprehensive evaluation to make sure the donor is healthy, both physically and also mentally, and capable to make an informed decision. And we talk to them about what is involved with the process of donation and kidney donation and what could happen in the future. That's their role to make the decision by weighing the risks and benefits for themselves. And I don't think it is fair for the patient who needs the transplant to make that judgment on their behalf. Sometimes the pairs come and they're not compatible, let's say because of the blood type, or sometimes because of the sensitization, or other factors. So we have a way to go around this problem. So let's say donor 1 and recipient 1 come to us and they can't go through the transplant because of incompatibility between the two. Now another pair comes to us with the same problem. What we could do is match the donor 1 with recipient 2 who has a compatible blood type, and match donor 2 with recipient 1 that are matching pair. So this way, both patients undergo transplant and enjoy the benefits of transplant, and both donors donate their kidneys on the behalf of their respective recipients. Sometimes we need more pairs, 3, 4, or even more pairs to shuffle around to find the right matches among them, so all of the recipients can get a kidney and all the donors can give their donors the kidneys on the behalf of their recipients. So don't think that since you think that the donor doesn't match with you for whatever reason, that's end of the line. We have solutions for that. Now let's ask you another question. True or false? A living kidney donor can't be older than 60. I'll give you a couple of seconds to think about it. That's false. The number of for the age is not per se is a factor that we disqualify a patient, a donor. As long as the individual is healthy, with a healthy kidney, and without major risk factors for bad outcomes after the surgery, after donation, the donor could be in 60s, or even we have had donors in 70s that donated a kidney, and they're doing well afterwards. On the other end of the spectrum, it could be 18 or 19 years. So age per se is not a factor for exclusion of a donor. Now, a female kidney donor Can she get pregnant after donation? Is it true or false? For those who picked true, you're right. The donation is not going to impact the potential for pregnancy after donation. Of course, you're going to recommend waiting for a few months for the recovery after the surgery and everything to settle. And the remaining kidney needs time to compensate and get bigger and more function. But afterwards, the female donor can become pregnant. There is a slight increase in the risk of some of the problems that may happen during pregnancy, but with close observation and monitoring by specialist obstetrician, and if nephrology help is needed by a nephrologist, they can go through the transplant pregnancy safely. In terms of the type of surgery, in contrast to the old time that the removal of the kidney requires a big incision, now this procedure is done by laparoscopic surgery that only very small incisions are needed. And with newer technology, some centers in the country, including the University of Maryland Medical Center, use more advanced robotic surgery to perform donor surgery. And you'll hear later in this program about that. Since the incisions are smaller, there's less pain. The hospital stay is shorter. The recovery is faster. Getting back to usual activities, work is faster, and the donors are more satisfied. Is it true or false? The kidney donor will usually be in the hospital for about 1 to 2 nights after surgery. What do you think? You're correct. It is true. Again, for the same reason that I mentioned, the hospital recovery is fast. The donor needs to be only in the hospital overnight or maybe for 2 days before being discharged. They may have a little bit of pain and discomfort that is usually well controlled with pain medications. So recovery is fairly quick. Usually the full recovery happens within maybe 4 to 6 weeks. There may be a little bit of pain that is well controlled after the surgery for a few days. There is no special dietary restriction. We just recommend a healthy, balanced diet and adequate fluid intake. And usually the donor can get back to what they were doing in the before the donation, including exercise and sport activities within about 4 to 6 weeks. The surgeon will discuss this with the donor during the process of evaluation and afterwards. Now the question is there a risk? There is a small risk of different forms of complications from living donor donation, but that risk is fortunately small. And again, it's up to the donor to decide who wants to take that risk of small transfer complications versus satisfaction from helping a loved one. Sometimes the surgery becomes complicated by bleeding issues. In unusual cases, they may need blood transfusion. Sometimes infections could happen, and it's low risk, and usually it's well treated with antibiotic. In the early after surgery, early phase, there may be urinary tract infection or pneumonia. but again, usually they respond very well to antibiotics. Blood clot formation in the legs and detachment and traveling into the lungs is an uncommon complication, but it's possible. We use certain measures to minimize that risk. Some donors may take a little bit longer than others to recover completely, which is expected with any other type of surgery. There is a small, very small increase in the risk of developing kidney failure several years down the road after donation. And the small risk of developing hypertension over years after donation. Again, those risks are fairly small, and they will be explained to the donor during the evaluation process, and the donor will let to decide if they want to take that small chance or not. And as I mentioned previously in previous slides, even if one develops kidney failure down the road, one of the features on the list, waiting list, that helps with addressing the sacrifice and acknowledging that is giving priority for transplantation for this type of individuals who develop kidney failure after kidney donation. The risk of death is very low. Fortunately, in our center, we haven't had any such incident, but other centers have reported a very small risk of death, which is about 3 deaths in every 10,000 donor surgeries. The kidney donation should be completely voluntarily and altruistically. There shouldn't be, and there cannot be any financial compensation or any type of compensation in other forms for living donation. It is illegal. However, the donor may suffer some expenses related to the travel for the evaluation or for the surgery, housing around that time, meals during that time, or in some cases, lost wages. So for this type of financial risks, there are resources available to help to cover at least a part of those costs. And our transplant social workers, or transplant coordinators, or living donor advocates are great resources that help our donors to find appropriate resources if needed. So what is the next step for a patient? First step, again, is being evaluated for being listed for a kidney transplant, like anybody else. And meanwhile, if one has a good candidate for living donation, we can also start evaluating the donor to expedite the process. And if the donor is deemed to be appropriate donor, and the patient has completed the evaluation and has been given green light, then the transplant can be scheduled. So the first step is getting connected to a transplant center to start the evaluation process. And if there is no major factor that could reduce the risk of transplant, then the living donor process can also start. In the next sections, we can talk about how do one find a living donor? That's a big question that we get asked all the time. So, as I mentioned in previous slide, first step is being evaluated for a transplant. Now that you have been evaluated and you're deemed to be appropriate to proceed with listing and transplant. That's your task, to find a donor. To find a donor, you need to share your story. People need to know about you and your need of kidney transplant. This doesn't need to be your immediate family members. Doesn't need to be your close friends. You have to expand this circle to include as many people as possible, to share your story, to elicit the question if they can be a donor or they will be willing to give you a kidney or not. If people don't know about your need, no one can expect them to step forward and give a kidney. So share your story, get help from your family members and friends to spread the word. Let others know. Expand this net, informing people about your needs and your story. Let's look at some of the examples that other patients have used that have been successful. Joe set up a free online blog to share his need to kidney transplant, the way that he suffers from different problems with dialysis. He kept his blog updated and shared that information with his family, with his friends, and the community members. And finally, someone from his church stepped forward and gave him a kidney. Bobby's son needed a kidney. She got his permission to let others know about his kidney failure. And she used as many ways that she could to spread the word. She shared it on social media, used the school and community newsletters. She asked people in the places of worship, in the community groups. She handed out flyers to people that she knew, asked for their help. And that's how her son got a kidney from a living donor. Alan and his wife, Aisha, shared their story on Facebook, asked people to help them, to spread the word, to find a donor for them. They built a network of advocates to spread the word. And finally, a friend of a friend of a friend stepped forward and gave him a kidney. Let's listen and watch this video about their journey in finding a donor.
I was diagnosed first with kidney disease in 2003. My health started declining, and it got to the point where my kidney function came down to 9%.
Alan received a notice from his nephrologist, hey, you're going to want to start looking at a transplant.
It was definitely a shock because I had just gotten married a couple of years ago, and my wife and I had so many plans.
Sometimes, taking a trip somewhere or going out somewhere, he would get very tired. He would fall asleep, and it would frustrate the heck out of me. I wasn't sure, are we gonna make it? Can I deal with this?
My journey with kidney disease really came full circle when I started working on the Big Ask, Big Give website here at the National Kidney Foundation. It's just a surreal moment that it hits me that the information on this website and working here and everything I've learned over the years is really what's going to get me through this. I'm a very private person, and for me, my issue is that whatever happens in my life is my own burden, and it's not something I want to put on someone else. I had to get past that issue, and it was my wife who helped me get past it. She said, your kidneys aren't getting any healthier. Nobody in my family was able to give me a kidney, so it's time that you reach out to other people. The idea behind the Big Ask Big Give was to actually put a post up on social media. We kind of worked with the template that was in the Big Ask Big Give website.
The scariest moment, are we gonna find a donor? Am I not going to have my husband around for much longer? The emojis and the comments were just starting to pour in. People were willing to immediately share our post and spread the word and get it out there.
My post ended up going viral, and it wasn't a direct connection that ended up being my perfect match. It was someone sharing the post and someone seeing the post on their Facebook page.
I was just scrolling along, as you do, and it really popped out at me. There was a voice in my head almost that said, this is something that you can do. This is someone who you could help. And it was easy. All I had to do was click on a link that was in there and fill out a quick questionnaire.
The day I came home and he told me that we had a match and we have our donor, I was speechless for like a good 30 to 45 minutes, and that's a lot for me.
You know, I still can't fathom it, that there's someone out there who saw my post and was generous enough to give me a kidney transplant.
And it was all so quick. Before I know it, the anesthesiologist was trying to distract me while they put the IV in, and the next thing I knew, I woke up in recovery. My thoughts after that just went to him. I hope everything's going okay. Was the kidney okay?
It's been 4 months now since the transplant. This is probably the best I've felt in the last 5 to 8 years, I think.
He woke up and it was a whole new day for him. The first day of his whole new life.
The big ask, it's scary. It's asking a patient to understand that it's okay to ask for help.
It's a big give, but it's also a big payback, and that's Alan in my life.
He's absolutely worth it. And there is no one else that I can imagine being on this life journey with than Alan Stephen Commuto. And I am so proud that I have the opportunity to be his wife and the opportunity to go through this journey with him and to support him. We went through the ups and the downs because we had to get to this point. And if that means sharing our journey with other people to make it that much easier for them, happy to pay it forward.
Let's move on to the next section. That now that your transplant has happened, what happens after transplant? So the surgery itself and getting a kidney is the kind of the beginning of the journey. The important part is after you go home. That's when we need to make sure that the kidney and you as a patient are doing well. The medications are appropriate. The kidney function is stable by looking at your regular blood test or urine test during your visits with the transplant providers. Your immunosuppressive regimen is adequate and appropriate. You're not getting or taking too much anti-rejection medications that has its own side effects, or you're not taking too little, inadequate amount of anti-rejection medications that could lead to rejection. And that's very critical, that patient needs to follow up regularly with the transplant physicians, perform their blood tests and urine tests as instructed, and take their all medications, particularly the rejection medications, religiously on a regular basis. That's the way to enjoy the kidney transplant for a long time. Our current medications are fairly potent. The risk of rejection is small. But despite the fact, sometimes some patients experience rejection, or sometimes some patients are not taking their medications as they are supposed to, or they don't get their labs in a timely fashion, so we find out about the adequacy of their immunosuppression, and then they may experience rejection. Usually the rejection, especially if it's mild, there is no specific symptom. We can find out only by looking at the blood test or the urine test. So that's why it is so important to have regular labs as instructed. In more severe cases, sometimes patients may have some symptoms like fever, like pain on the kidney, or change in the urine that may indicate rejection. And usually we do a biopsy of the kidney and treat the rejection. And fortunately, in most cases, we are successful in controlling the rejection. Now, after a surgery, one needs to know when one can go back to work. Usually, the recovery takes around 8 weeks. In some patients, it's faster. In some patients, it takes longer. And when you can go to work also depends to some extent what type of work you do. If one does a desk job, sitting behind a computer, that doing distance work at home, yeah, one might even start within 4 or 5 weeks. If someone is doing heavy work, then we might ask that patient to get the supervisor and the employer to give them a lighter job, like desk job, until the recovery, and then go back to old job, or wait even longer than 8 weeks until the wound is completely healed before lifting heavy objects. Again, the transplant surgeon and the transplant team, the physician, will determine that time frame and let you know after the surgery. Now, one might wonder, after transplant, is there a need for special diets? Sorry. Generally, most of the restrictions are removed after transplant, and one actually is encouraged to drink more fluids to keep adequate amount of hydration. And many of the restrictions are lifted. In some cases, we even need to encourage you to eat things that you couldn't eat before, like things that have a high phosphorus content. I would like to thank you again for joining us for this seminar. I hope that the information that I provided was helpful and you learned a lot. And I would like to thank again the National Kidney Foundation and Patty's team and Patty. And I hope that I see you soon for kidney transplantation and see you after the surgery. Have a wonderful day.
Thank you so much for joining us for Session 1, First Steps to Transplant. We're now going to provide you with an evaluation link in the chat where you can take that now if you have a few moments, or please copy it and take it after the program. You're going to visit our breakout rooms now with our doctors. They will answer your questions, and then hopefully you're going to rejoin us for session 2, Finding a Living Donor. We promise you won't want to miss this. Thank you so much.